Hello, welcome to this episode of My CPD. And on this episode, we'll be talking about intravenous fluids and fluid replacement, knowing fully well that fluid therapy is one important component in medical management. My name is Admo, and today I'm joined by Mr. Kumbira Izurawa, who is a nurse anesthetist practicing at Nyanga District Hospital, and he's going to be discussing with me the issues around intravenous fluids. Mr. Kumbira Izurawa, intravenous fluids, a very important form of therapy within the clinical setting. We often encounter in our daily practices patients who are severely ill, who may be losing fluids or who may be needing fluids. So we just want to practically talk about IV fluids, their importance, how we choose a certain fluid over another fluid. So maybe as a way of starting broadly, how do we classify intravenous fluids, and what maybe sort of examples exist in each of these intravenous fluids?
Thank you for having me, Dr. Jokwiro. Broadly speaking, there are two broad classes of intravenous fluids. We have crystalloids and we have colloids. You can also talk of blood and blood products, which can be classified under colloids. So basically, with crystalloids, we have examples like normal saline, ring lactate, 5% dextrose, half darus dextrose. Those come under crystalloids. And examples of colloids are voluven, hemacil, and gelafuscin, just to mention a few. Those are the two broad classes, and the differences between the two broad classes is just particle size. With colloids, we have a bigger particles in them, bigger molecules in them, and largely it's gelatin that we find in these colloids. With crystalloids, by way of definition, a simple definition that I can give is it's water plus electrolytes. These are the biggest difference. And with these crystalloids, you would also want to know that once infused into a patient, they spend very little time in the vasculature as compared to colloids. Colloids take a longer time in the vasculature and they expand volume. Basically, that's what I can say on the two broad classes.
Okay, so talking about these classes, crystalloids, colloids, what sort of advantages or perhaps disadvantages, if any, do they have maybe over each other or within their own categories?
Yes, with crystalloids, I would like to start with crystalloids. These are the most widely used. And in every health facility, you are bound to find these ones. They are very much available. And that's one of their biggest advantage. They are cheap to acquire, readily available. They have a long shelf life. You probably want to know as compared to blood and blood products, they take long for them to expire. So a long shelf life is one of the biggest advantages they have. They have a low risk of anaphylaxis or reactions. This is one of the biggest advantages we have with crystalloids. You also want to know that with crystalloids, they are acceptable even with those people with a religious background that refuse transfusion. These ones can come handy, and we have seen that most of our people will not refuse to be given crystalloids. That's a big advantage. Okay. Coming to colloids, colloids also have a big advantage that I mentioned earlier on, that they expand volume because of their nature, that they have larger molecules in them that confine them in the vessels, which is very important as compared to crystalloids. That's a big advantage with colloids. The downside of colloids, however, is that as compared to colloids, that they have a much bigger risk of anaphylaxis as compared to crystalloids. That's the downside. But these ones can also be very useful in fluid replacement.
Okay, so I want to come down to some practical scenarios where we use fluids, or rather where we have fluid replacement. So we encounter scenarios, often people coming in acutely ill, maybe they are unconscious and they cannot be able to take fluids, or maybe somebody is hemorrhaging, say after a road traffic crash, or another form of accident trauma. Sometimes septic patients, sometimes severe burns. So one clinical scenario that we often encounter where you have to give fluids is shock. What would you probably, as probably a simple definition, what how would we define shock, clinical shock?
Okay, clinical shock is, in simple terms, is when we have a patient coming in with a very low blood pressure that is unable to perfuse vital organs. When I say a very low blood pressure, I mean a blood pressure with a systolic of less than 90, and also a blood pressure with a diastolic less than 60. That's practically shock. That patient is practically in shock, and fluids come handy in resuscitation and reversing shock. So with the type of fluids that we have with shock, in respect of managing shock, crystalloids as well as colloids can come handy. For example, you said a hemorrhaging patient. Crystalloids come handy in reversing shock, in getting that BP up. Also another aspect is pulse rate that we did not mention in terms of shock. They may come in tachycardic, which means they have a fast pulse. And if these are managed with fluid, you reverse shock. So fluid become a component of paramount importance.
All right. So still on this patient in shock, I want us to break it down further to be more practical. A patient is coming, they've just had a road traffic crash and they are bleeding, and I'm working at clinic level. So you said there are crystalloids, there are also colloids. I would want to know which fluid should I use, and for example, if I'm using a crystalloid, how much of fluid should I give? If I'm giving a colloid, how much of a colloid should I give? I want us to get to that practical level.
Okay. With the management of shock using crystalloids, you need to establish management of shock is tailor-made to our patients, but as you have said, that at a clinic level, and most of the fluids that you see at a clinic level are crystalloids, and you have them at your disposal to manage shock. You need to at least establish how much the patient needs, how much the patient has lost before you start infusing these crystalloids. But the basic thing is, when you're replacing a fluid in a shocked patient, probably after hemorrhage, you need to know how much that patient has lost, how much has been lost. And this can be arrived at by looking at the splashes, the linen, or vital signs can be a very big component in establishing how much a patient has lost. And when managing shock using crystalloids, the ratio you use is 1:3 for blood. For every ml of blood lost, you replace with 3 ml of a crystalloids. When managing using a colloid, colloids can be used to manage shock, and as I've said earlier on, that they stay in the vessel and they expand volume in a patient. This ratio you use is 1:1. For example, a patient has lost 2,000 ml of blood after an accident in RTA. You know, when you want to replace fluid using crystalloids, you are going to give 6,000 ml in this patient. But how you need to take care of the way you are going to give the fluid to the patient. So 1:3 for crystalloids and 1:1 for colloid is very important in infusing patients.
Okay. So I'm clear on the ratios. With the example that you have given, my patient comes in, they have lost 2,000 ml of blood. I'm going to give 6 liters of normal saline or 6 liters of ringer lactate. My patient has lost 2,000 ml of blood. I'm going to give the 2,000 mils of gelofuscin if I'm having a colloid.
Yes.
But I also want to know the rate at which I can actually give this fluid, because I think in some instances we have encountered things like fluid overload, pulmonary edema, which are hazards maybe of rapid fluid replacement. So how do I calculate the rate at which I should replace fluid?
Yes, the rate at which you give the fluid is very important to take note of, because once you give the 6,000 liters for the patient we discussed earlier, 6,000 mils of crystalloid at once will not actually do good to this patient. So there's a way you do it. Once you establish how much you need to give, for let's say 6,000 liters, you can't just pour it in at once. What you need to do is, there's a formula that we have devised to give the fluid. The first, you divide the amount of fluid that you want to give into two. The first half is given in the first hour.
Okay.
Then the second half, you also divide that into two. So a third of that fluid, a third of the whole fluid is given in the second hour, and the last third in the third hour. Then you go back to your maintenance. You would have replaced fluid in a systematic that will not cause problems to the patient. So what is important, why the take-home point, is that you don't pour the fluid in at once into a patient, but it has to be done systematically. I will repeat it again. Once you establish how much you want to give to the patient, first half of the fluid is given in the first hour. Then you divide the remaining half. The first third you give it in the second hour, the last third you give it in the last hour. That's how you infuse using crystalloids. With colloids, you also have to do the same, so that you don't overload the patient with fluid in a short space of time.
All right. I think that's quite clear and well explained. Thank you. So you bring in the concept of maintenance.
Yes.
You have said that as soon as I've finished replacing the deficit, which is the 2,000 mils of blood lost, and I've given the 6,000 mils of crystalloid or the 2,000 mils of colloid, I go back to maintenance. This concept of maintenance fluid, we also encounter it in some sick patients who cannot possibly be able to swallow, who are not taking in fluid, like severely ill patients or patients who are being starved in preparation for surgery. How do we go about the aspect of maintenance fluid? How do we calculate the requirements?
The requirements as per maintenance fluid is very simple. Firstly, you need to know the patient's weight. Fluids are given based on patient weight. So, maintenance fluid, in a nutshell, is when you acquire the patient's weight. Let's say the patient is 60 kilograms. You need to calculate how much you give as maintenance per hour. There's again a formula that has been put in place to calculate maintenance, among other formulas, but this one I find to be very easy to use. The 4-to-1 formula. 4-to-1 simply means, if you take patient's weight, you know they are 60 kgs. The first 10 kgs of this patient's weight, you multiply by 4, which will give you amount of mils. 4 by the first 10 kgs will give you 40. That's 40 mils. Then the second 10 kgs of the patient will multiply by 2. 4 by 2, which will give you 20 mils. Then the remainder you will multiply by 1. So in this 60 kg patient, which means it's 40 plus 20 plus the remaining 40 kgs by 1, which will give us 40. So 40 plus 40 plus 20 will give us 100. So this patient's maintenance fluid is 100 mils per hour. That's how you come about the maintenance fluid of a patient based on their weight.
Okay. All right. Quite enlightening. We have talked about scenarios where we give IV fluids. We have also talked about how we actually give the fluids. But I think the objective of giving fluids, which is what you hinted on earlier on in terms of the goals of fluid replacement, is to restore perhaps the normal physiology of an individual. So how do I tell that I've given enough fluid? How do I avoid overdoing it? How do I sort of monitor a patient when what do I look at? What parameters do I look at?
Your vital signs are very important in patient monitoring on fluid, and to come to a conclusion that you're giving enough fluid to the patient. We want to restore a normal blood pressure. We want to restore a normal pulse for the patient. We also have to see that this patient is well hydrated. How do we look at that? Urine output becomes a very important monitoring tool. So all patients receiving fluids, especially in resuscitation or maintenance, they should have a fluid chart. Should actually see urine output, what you have given and what you are producing in terms of urine. So normal urine output is 0.5 to 1 ml per kg per hour. Once you achieve that, you know you are perfusing your kidneys very well. So vital signs are very important, including urine output in monitoring during fluid replacement.
Okay, thank you. I think that's almost about it in terms of a brief look at intravenous fluids. But we have a few examples which are here with us, Mr. Zurawa, and I think it would just help if you could just share on how, fluid composition. What is in these fluids?
Okay, I'll start with the crystalloids, as we earlier on alluded to. We have our normal saline here. Normal saline composition is just water plus electrolytes, which I mentioned earlier on. And the electrolytes that we find in normal saline is sodium and chloride. That's it in normal saline. And we also have ring lactate. Ring lactate is a crystalloid with much more electrolytes in it as compared to normal saline. And in ring lactate, we still have the sodium, we still have the chloride, but there are additions to it. Magnesium is also there, potassium is there, and there's lactate, which is converted somehow to bicarbonate by the body. So that's to do with the crystals that we have here. We have colloids. Colloids, the examples that I gave here today, we have gelafusin, we have foluven. And in both these, we still have, in gelafusin, we have gelatin in it, 4% gelatin. That's those molecules that I talked about that make crystals different from colloids. Gelatin is these are larger molecules in it that make them stay in the vasculature for a longer period. We also have foluven with us. These two are colloids, and these are our crystalloids.
Okay, and these are accessories like the fluid giving sets?
Yes, we have our fluid giving set. Each time you want to give fluid to a patient, we use fluid giving sets for our crystalloids and for some of our colloids. But when it comes to blood, as earlier on said, it's also one fluid that we meet in our wards when transfusion is has been ordered. We need to give blood, and blood giving sets are used instead of fluid giving sets, giving blood and blood products.
All right. So again, I want to go back to the clinic at the remote level. Yes. I am not able to find intravenous access. Can I give fluid orally or via nasogastric tube? Can it help?
Yes. When you fail to establish intravenous access, there are so many ways of giving a fluid to the patient which is not intravenous. As you mentioned, nasogastric tube can be very helpful when you need to give fluid. Oral intake, this is the normal way we maintain normal fluid in our body when we are not sick, when we are not in any problems. We always take a fluids orally. That's the primary way of getting our fluid in. But when patients can no longer get fluids orally, we resort to these other forms, intravenous access, and give fluids intravenously.
Okay. So on a lighter note, I don't have these intravenous fluids, and in terms of even the oral fluids, I don't find water. Can I use alcohol?
No, no, no. Alcohol, it cannot replace this because of its nature. But we encourage people to get water.
Okay. Thank you so much, Mr. Zurawa. It was quite an enlightening discussion that we have had on IV fluids, and I would want to wish you a safe trip back to Nyanga. So there we have it. Today we did discuss at length on intravenous fluids, how we can be able to make practical use of intravenous fluids in certain circumstances, like a clinical shock, for example, when a patient presents acutely after an accident and they are bleeding. So I hope we were able to get a few concepts around the use of intravenous fluids, especially the use of ratios when you are looking at crystalloids and colloids. Thank you so much.